as soon as Hello and welcome to Hernia Patient Support Group and to our live chats. My name's Jackie and I'm one of the admins for the group, and I'm delighted tonight to be able to introduce you to a very special friend of mine, Mr. Christian Macutkiewicz from Manchester Royal Infirmary and also from the Spire at Manchester. Christian is also the current president of the Association of Surgeons of Great Britain and Ireland, and we're very lucky to have him join us tonight to talk to us about emergency hernia surgery. So, welcome, Christian, and thank you so much for joining us tonight.
Thank you so much, Jackie. It's a real privilege to be able to do this for you, and it's a subject very close to my heart. So anything I can do to help the hernia patient community is worthwhile.
So this discussion will be recorded and it will be available on YouTube later for people in the future. There is opportunity if anybody wants to ask Christian any questions later. If you just use the chat function and then we can put them to Christian. So I think when patients develop a hernia, the thought of it becoming an emergency is something that is really quite real for people. What are the warning signs that you think people should look out for?
So the first thing to say is that most people with hernias don't come in as an emergency. And so I don't want patients to think if they've got a hernia that they're going to have an emergency and it's going to be horrendous. So most people don't. But the early signs that there is something not quite right is if the pain changes. So most hernias get a discomfort around where the bulge is. But if the pains should change, so I'm going to talk about two different types of hernias. There's the middle hernias, the ventral hernias, that's hernias on the front of your tummy. And then there's groin hernias. I'm going to take the two separately because they have different symptoms. So groin hernias are usually discomfort or a little bit of discomfort and pain down in the groins. Most of the time, they can go back in when you lie flat, or you can sort of massage them in and there's no problems whatsoever. Sometimes they stick out, stay out, and the pain changes. It becomes constant. And that's one of the reasons why patients then get alarmed that something is strangulated. And strangulated means that a hernia has gone into the hernial sac and it can't go back inside. And that's one reason to come into the emergency department to have it assessed, because sometimes surgeons with a bit of analgesia can put it back in for you and relieve you of that pain. For groin hernias that suddenly change and cause you pain in the middle of your tummy, that means there's a piece of bowel in there that's not very happy. And those are the situations you absolutely need to come to the emergency department, and you need to come and have that either reduced urgently or operated on. And we do them as an emergency. So that's groin hernias. Midline hernias and ventral hernias, and often patients have had previous surgery and have something called incisional hernias. Now, these usually fall into two groups. There's incisional hernias that have got a really wide defect. And by wide, I mean something that I can put my fist in the defect when they're lying flat. And that's a really wide area for intestines to go in and out of the hernial sac. And those usually don't present with strangulation or with incarceration because there's a really wide gap. The smaller gaps are the ones that usually cause you more problems. And again, if the hernia pops out, won't go back in when you are lying flat, or if you try your usual massage maneuvers to go back inside and it won't go back inside and it's causing you constant pain, those are good reasons to come into the emergency department. And again, what we normally try and do is give you some morphine and try and reduce it. But sometimes if it's really tight, so when they've got a small neck, then those are the ones we can't put back. And those are the ones that we usually operate on as an emergency. So those are the things that I want you to think about when it comes to when should you come in. But I say this again, majority of patients do not come in as an emergency.
No, hernia tends to be that it's not a life-threatening condition, is it? It's normally pretty safe to wait for the watchful waiting for most people is an acceptable form of treatment.
Yeah,
So when it is an emergency, though, people haven't actually had any prehab, have they?
no, and
So
that's the issue.
yeah, we tend to talk to people about preparing for surgery from the minute they realise that they've got a hernia. So maybe cutting down on smoking and stopping smoking because that causes the wound issues and the delayed healing. Try and lose some weight if possible, which isn't always easy when you've got a hernia and they can limit your mobility.
Limit your mobility. Yeah. So in terms of what you can do to optimize yourself, I cannot tell you what an effect giving up smoking for 6 weeks does on your surgical outcome. It really reduces your rate of infection and poor wound healing. And that's because not only does the cigarette smoke affect your lungs, but it affects the small vessels in your skin, which are used for healing. And so you don't get as much oxygenated blood to your tissues. And so the actual tissues don't heal at the same rate or as well as the average person who doesn't smoke. In terms of giving up, reducing weight, it's it's not that it's not that obvious, but when you lose weight, you actually lose weight in your hernia as well. So you might lose subcutaneous fat, but you lose fat inside the hernia. And actually, sometimes that makes the hernia smaller and a lot easier to treat. But in the emergency setting, if you've lost some weight, actually bringing the tissues together to fix your hernia is a lot easier. Now, there's been lots of studies about losing weight and outcomes for surgery. And the figure that everybody reads in the internet and on the papers is having a BMI of 35. Now, a BMI isn't it's the best tool we've got at the moment. But if you are a big muscular rugby player or somebody that does weightlifting, your BMI might be really high, but actually you won't be very fat. So it's a very crude assessment. But for the average person, if you can bring your BMI down to 35, that reduces your complication rate by 40%. So that means you're more likely to get a better outcome, less likely to have a recurrence. And a recurrent hernia is so much harder to treat. So that's why all of us hernia surgeons really try to get patients to reduce weight as much as possible.
That's brilliant advice because I mean we do have some people who tell us that the surgeons aren't able to operate on them because of their BMI, but then they'd only operate if it became an emergency. So I think it's important to understand the reasons why patients are asked to lose the weight and to do some prehab for themselves to
Absolutely.
get the
And
best possible
yeah,
outcomes.
absolutely, Jackie. And this is the key. And I think if this is the thing that patients understand the most from this evening, I think it will be a really good thing. So the reason we ask patients to lose weight or maybe refuse to do surgery until they've lost weight as an elective planned operation is my job as a surgeon is to give you the best possible outcome. And the best possible outcome for me is you go home, you don't have an infection, and you don't get a recurrence. And the best ways for that to happen are to lose weight to get a BMI of 35 or less, to not smoke for 6 weeks. If you're diabetic, to have really good diabetic sugar control. And if you manage all of those things, that reduces your risk of a bad outcome massively, well over 50%. So if I said to you, if you did all of those things, you've got a 50% chance that your hernia will heal better that you won't get an infection, that it will never come back, and that you'll live a normal life, people should normally take that. I would take that. The reason it changes as an emergency is when somebody comes in and is as an emergency, it's usually because it's bowel that's involved in the hernia. And as an emergency, the life-threatening thing isn't the hernia, it's the bowel that's going to die inside it. And so as a surgeon, our priority is to save a person's life and get that bowel reduced and back inside. The hernia is a side issue, and the majority of patients who have a bowel incarceration and maybe it's not very happy will have a hernia fixed with sutures, because we take the line that it's better to save the person's life, get them through the major operation, and then come back at a later date to have a planned operation for the hernia. And that's called a staged treatment. So fix the emergency bowel problem, then come back and do the hernia. Sometimes, if it's a small hernia that doesn't need a mesh, then we would fix that, and it's probably all you ever need. So little belly button hernias, for instance. But for big incisional hernias, we would do a planned operation.
Yeah, we did a survey within the patient group for the new emergency hernia surgery guidelines, which are just about to be published. And the results of those showed that most patients were happy to have a 2 or a 3-stage repair if it meant that they retained their full bowel function and they had a better quality of life later down the line with no mesh infections or anything once the bowel had recovered.
100%. And sometimes I don't think we're very good at explaining that to patients, why we're not fixing the hernia definitively. And it's important that we take time to talk to patients to explain why we're doing this, because I think some patients can be quite angry if they find out that the hernia was the side issue. They would think that they're having everything fixed in one go. And actually, it's our job to make that clear and understandable for patients. The emergency thing is to save your life, and the hernia is something that we come back to live and fight another day.
Okay, so what would be the consent process be like then for an emergency surgery? Is it similar to as an elective surgery?
So I think with emergency surgery, the consent process is exactly the same. The only things that are slightly different are the complication profiles. So if I go through a standard hernia consent process, we'll go through the reason we're doing it. We want to do it to reduce the hernia and try to prevent recurrence. And then depending on the hernia, I will say the first 4 risks are the same as any operation: having an appendix done, having a toenail operation, anesthetic, bleeding, infection, and blood clots. And there's something in place to stop all of those things from happening. So you get intravenous antibiotics while you're asleep. So there's antibiotics going around the system at all times to try and prevent mesh infections, because mesh infection is the thing that we do not want. As surgeons, that is the disaster, because most meshes don't do well with infection, and some of them have to be removed, and then we've gone all the way back to square one. So the first 4 risks are the same for anything. And then I usually mention other things that are really common with hernias. So seroma, which is a collection of fluid. And if you think about when you burn yourself, you get a little blister. Let's say you've burnt yourself with an iron, you get a blister. That yellowy straw-colored fluid is what a seroma is made of. Now, it's sterile and it's benign, and most of the time your body absorbs it just like it does a blister. Sometimes it gets really big and we have to stick a needle into it. Very rarely do we need to stick a drain in it or even more rarely, we have to take a patient back to theatre to remove the seroma. So seroma is quite common, but usually you don't know about it and it absorbs itself. The next one is hematoma. And hematoma, if you think of a seroma of a collection of fluid, a hematoma is a collection of blood. Now, sometimes when you do emergency hernias, there's a time pressure. Somebody's unwell and you need to get in quickly and fix this thing as quick as possible. And so you have to balance speed with cauterizing every single blood vessel. And often speed is of the essence. And so you have to accept that there will be a hematoma. Again, most of the time, we don't do anything about it. It's like a bruise, your body absorbs it. Other things that are more common with emergency is chronic pain. Now, chronic pain is different in everybody, and it's the rates are different depending on what type of hernia you're having. So if it's in the groins, it can range anything from 2% all the way to 20%, depending if you're having it open, keyhole, if you're a man or if you're a woman. So that's groin hernias. Abdominal wall hernias or midline hernias, that can be anything up to 20%. And there's lots of reasons why somebody might get chronic pain, whether they've got some tacks or staples into the abdominal wall or stitches that have caught a nerve, or whether there's mesh irritation. There are lots of causes, and I'm certainly not clever enough to know all of them. In terms of other things that I normally mention, I do mention recurrence, and recurrence is really important to try to help a patient understand that when you are stitching a thin abdominal wall, it's sometimes like stitching tissue paper together. And you can imagine if you're stitching tissue paper together, it doesn't take a genius to know if you pull it, it's just going to fray and pull apart. And that's what some people's abdominal walls look like as well. So we normally have a grading of what percentage chance you have of getting a recurrence, and it can range from anything from 10% all the way up to 50% in the emergency setting. And it's important that your doctor gives you an idea as to what your risk is. It's not an exact science. We do it on the experience that we've done. I've been a doctor 26 years. I can't believe I've been a doctor 26 years. But
I wouldn't have said you're old enough, Christian.
That's the reality. You get a feel for hernia surgery, and surgeons that specialize in hernias have got a better feel for it because they do lots. And I think that's really important.
I think one of the things that worries people, though, is in an emergency setting, you're not necessarily going to get a hernia surgeon, though, are you? It's whoever's on duty in A&E that night.
You're absolutely right. What I can say about that, however, is for normal hernias, any general surgeon usually can fix that. And in an emergency setting, they fix the emergency bit and then they do their best with a hernia. In complex situations, we often call a friend. We often call somebody, let's say somebody isn't a hernia surgeon and they've got into trouble. There is usually somebody around who does a lot of hernias that can come and give advice. Where I work, there's 4 of us that work together who often call each other to say, can you just come and have a look at this? Or other surgeons who aren't hernia specialists call us to say, Christian, I've got a bit of problem closing the abdomen. Can you come and give me a hand? And we go there and we help them to do that. So even though you may not have a hernia specialist looking after you, there's usually one in the building and we're usually called for help.
And the other thing to think about is also in the guidelines, if you're not experienced, surgeons can have a quick look at the guidelines, which are there, and it does say just save life, the hernia comes second, and just
Absolutely.
that is the main thing.
Yeah.
Okay, so when some people get told they've got a partially reduced hernia, partially reducible hernia, is that something that they should be worrying about?
So partially reducible means that most of the hernia or some of the hernia goes back in either on its own or with a bit of massaging. Now, my advice at the beginning of this webinar, where the pain character is really important. So if it's a partially reducible hernia, it's usually hernias that are quite big, because
Right.
a small hernia is either reducible or it isn't. But if it's partially reducible, it's usually quite a big hernia. And as long as there's no pain or the discomfort hasn't changed, there's nothing to worry about. If it suddenly becomes a lot bigger and won't reduce, won't go back in, either on its own or with manipulation, with massage, then that's a reason to come into hospital. And we often have patients like that, Jackie, that come into hospital. We give them morphine, we make them relaxed, and it partially reduces back to its normal state. But sometimes you do need the strong painkillers to allow us to for that to happen, because the muscles the muscles are clenched around it, and they have to relax to be able to let the hernia reduce back inside.
Right. Okay, that's fair enough. So, what would you describe as normal hernia pain and an emergency hernia pain? Because hernias can be quite painful anyway, and
Mm.
people struggle very much day to day, especially with the larger hernia.
Yeah.
We have people surviving on some really strong medication, and I remember from when I had my hernia, it was really painful.
So normal hernia pain is the background pain that you all deal with on a day-to-day basis. Some people, it's agony and they have to take loads of painkillers. Some people describe a dull ache that's around there all the time. And some people describe a sharp pain which catches them when they do certain movements. When your normal, inverted commas, pain changes, when the character of it changes, that suggests that something's happened inside that may be something to worry about. So if it gets bigger, if it gets tense, that means it's harder than usual. Or if there's any skin changes. So sometimes we look at the skin, and if it turns purple or if it's gone red, that suggests that whatever's inside the hernia isn't very happy, and you should absolutely come into hospital, especially if you've got skin changes and the pain is a lot worse. So for patients like yourself, Jackie, if the intensity of the pain suddenly got a lot worse, or if you're vomiting, that suggests that the bowel inside your hernia has got a twist in it or blocked. And often we can help with that with a tube down your nose, going into the stomach to release all of the fluid from the hernia sac. And that can sometimes decompress the hernia and get you out of trouble. That's called an NG tube, a nasogastric tube. But it's only really by coming into hospital that we can assess that and see if that would work.
Okay. So what about bowel function? Is that a symptom as well? If somebody's having difficulty passing a bowel movement or passing gas, should
Yeah,
that
so
be?
that's a really good point. So if you've got bowel or intestines in your hernia, there's two types of intestine. There's small intestine and there's large intestine. Large intestine is the bowel towards the end that stores all your poo, and small intestine is the digestive type of intestine. So when you have a hernia that's got lots of small intestine in, if it blocks, then you often still can go to the toilet, but probably not as often, because there's still the colon that's got some poo in it. And so people are sometimes mistaken or misled by the fact that the patient's still opening their bowels, even though they've got an obstruction in their small bowel in the hernia. If you've got large bowel in your hernia, then the symptoms are different. And if that's blocked, then you don't open your bowels. And more importantly, you don't even pass wind. So if you can't trump and you can't open your bowels, that suggests that you've got a large bowel obstruction. And that is absolutely an emergency. You have to come to the emergency department and you need to be seen by the surgical team, because you're looking at an operation at that stage.
So in these cases where it is becoming, there are any doubts and that it is becoming an emergency, is time of the essence to get to the emergency?
Absolutely. So what the textbooks say is a piece of bowel that's twisted or their blood supply is compromised has about 6 hours to live. And that's 6 hours from when it was twisted. So we can't tell when it was twisted. And patients often stay at home for a while battling with the pain. So I say time is of the essence. Just like when you have a heart attack, time is muscle. It's the same thing when you've got a bowel obstruction, time is bowel. And sometimes when we get it a little bit too late, the bowel is dead and we have to remove that piece of bowel. And then we have to either bring out a stoma, which can be permanent or temporary, or we do a join, which is called an anastomosis. And that's where you join the two bits of bowel together. And usually if we've done a bowel resection, if we've moved a piece of bowel and we've made a join, or even if we've brought the stomas out, the hernia, as we've said before, is a secondary issue. We would never usually put a mesh in because of the risk of mesh infection in those cases.
So we have a look at recovery now. So the ASGBI have they support the NELA project, don't they?
Yeah.
And the NELA website at the moment is not brilliant. It's I'm sure that they'll all agree with that, but it is under construction, and I have seen some of the new information on it, and I'm going to share with people now some of this information, because I do think some of it is really quite good. So this is the recovery document. I hope everybody can see that.
Yeah.
And this is talking about diet after emergency surgery, which I think is really quite good, because you will lose your appetite a bit after surgery, don't you?
Absolutely. Absolutely.
And I think it's whatever we can do to promote healing. Now, I will share this again in the within the Facebook group. It's about eating a balanced diet, but also I think we find that people also go through a bit of depression afterwards as well, because you've got to give yourself time to get over that. An emergency surgery is a traumatic experience for people,
Yeah.
and you need to allow your body to recover. And it talks here about having a positive outlook after your operation.
Yeah.
It's a big shock. You may need to make some changes to your lifestyle for a bit, and you may need help.
Absolutely.
And it talks about keeping your bowels working. Now, that's one thing that surgery has a habit of stopping the bowels from working, doesn't it? That they do go into shock after with all the pain
Yeah.
management, and they do go slower. So I think this is a
Absolutely. And
really
that's one of the downsides of having to take loads of painkillers, is it really slows your bowels down. And that's counterintuitive, because you want the bowels to be looser and going more regularly, so that you're less likely to have obstruction again, and less likely to have swelling in your tummy. But a lot of the medication that we give make your bowels worse. So it's a bit of a balancing act.
It is. And do you recommend then in them circumstances that if people are finding themselves becoming constipated, that a fibre supplement or something like fibre gel can help.
So that's really interesting. The thing that I normally tell my patients, and certainly my hernia patients, is I don't want them to push. I want Mother Nature
To
to
take its course.
take its course. So I want you to sit on the toilet and wait, and take a magazine or scroll through your phone and sit and wait. Because when you push, you raise your abdominal pressure so high that it can cut through stitches and it can increase your chance of getting a hernia recurrence. So making your bowels loose enough that you don't have to push is really important. And some people are natural pushers, and it's really difficult to get them to change that habit. So it's us as doctors to try and help educate them to say, look, actually, you need to change how you go to the toilet, because by pushing, you're really making the matter worse.
This says here about putting your feet on a stool. Now, I've heard that several times, to just pop your feet on a stool and lean forward. She's just good advice for people. If it works, it works.
Do you know how that works? It's really funny. So if you ever watch a dog going to the toilet, you'll notice that they really lean back, and so their bottom is really quite a lot below their knees, and that's the best position for the rectum to get rid of the poo. So actually, by raising your legs up on a stool, mimics that action, and so actually helps you to clear your rectum better. So there is a mechanical reason for it.
Right, right. So brilliant. I never knew that. So this here, what are the warning signs that people should be worried about after emergency surgery? The increasing
So I think
pain
it's
and
important. So I think it's important to say that most people who have emergency surgery have a good outcome and don't have any problems.
no,
But the
no,
things that you can look out for are, so if I take infection first, if you see that the wound is getting red, it's hot, tender to the touch, or if there's pus pouring out of it or seeping out of a little hole, then that says that you've got a superficial wound infection. Now, sometimes these can be deep and you can be really unwell. So infection is one of them. If there's a big swelling, that could be either a seroma or a hematoma. So if there's suddenly an increase in the swelling, that might be a reason to go and see your GP. And if they're worried, they will send you back into the hospital. If you've got new pain from around the wound that you've not had before, and you are distended, you're vomiting, those are reasons to come in, because you may have developed an ileus, or you may have adhesions and got a small bowel or a large bowel obstruction.
I think sometimes though your mind plays tricks on you when you're recovering from, and I think it's important to be aware that these symptoms are it's very, very rare that people get complications, isn't it? And
absolutely.
Most of the time it's just normal healing pain.
Absolutely. And one of the things I think, so all the textbooks and all the websites say you can go back to your activity after 6 weeks, and your hernia is fixed after 6 weeks, and you can go back to the gym and you can do things. One thing to say about emergency laparotomy and emergency abdominal wall hernias is, realistically, it's going to be 3 months at least before you're starting to feel back to normal, because you've been in hospital for 1 to 2 weeks. Most people lose quite a bit of muscle mass from their legs and their arms. When you get back to home, you'll feel tired and you'll feel the weakness going up the stairs. You won't be able to take the stairs like you used to. And sometimes you have to go halfway, rest for a bit, and then go back up. So you get really deconditioned when you have an emergency laparotomy. And I always say to my patients, realistically, it's going to be about 3 months before you're feeling normal, whatever.
100% agree. Yes, whatever the normal is. And sometimes it's a new normal.
It is,
Which
yeah.
I think this is a really good thing that this timescale here telling people. So I will share this later within the Facebook group, but for now I'll just stop sharing. But yeah, I think sometimes there is a new normal and you have to get used to that.
Yeah, I agree, especially with mobility. If you go into hospital and you've needed a stick before you go into hospital, most people go back home needing a Zimmer frame because you never go back to the activity that you're used to. So if you're fit and well 20-year-old, the chances are you'll go back home and you will be a fit and well 20-year-old, but it'll take you 3 months to recover from a laparotomy. But if you're a 70-year-old who's normally fit and well for 70, you have an emergency laparotomy and you're in for hospital for 2 weeks, most people will go back home and need a little bit of help, whether that's help with shopping, help with going around and doing stuff, or sometimes people needing people to come in the house to help them with cooking and moving around. So you get really deconditioned.
Yeah, that was going to be my next point. When we're in pain, it's instinct you want to curl up and just sit there and not move around, isn't it? But how important is it to be moving around?
So important, and I tell every patient. And actually, when patients are in as an emergency, sometimes the last thing they want to do is move, and they get annoyed when we go around on the ward round and say, right, I need you sitting out of bed, please. And they look at you as though, my God, I'm in agony here, and you're telling me to get out of bed. This is torture. The reason is you lose muscle mass after 7 days. So if you stay in bed for 7 days, you start to break down the muscle, and the ones in your legs are the ones that go first, which is why mobility is so difficult when you've had an emergency laparotomy. So we go around and get you to move to try and stimulate your legs and your arms so that you don't lose that muscle. It also has the benefit that it helps to stretch your lungs, so you are less likely to get a chest infection. And it also has a really good effect on the bowels. You don't think of your bowels moving when you're moving, but they do. So they're sort of swimming around inside you. And by the act of walking and moving, transferring from bed to chair, that actually helps the bowels to move around, and the peristalsis, that's where they sort of push food along. So although moving just seems like you're moving your legs, it has a lot more benefits: chest, bowels, and obviously you don't lose your muscle mass.
That's it is, and also drinking water can help with keep your bowels hydrated as well, isn't it? It's important to stay hydrated after surgery.
Absolutely. And you mentioned fiber gel and fiber. It's all right eating lots of fiber, but fiber tends to be like polystyrene. It just bulks up. If you don't drink the water, then you've got really bulky stools, but not much liquid to help push them through. So that can sometimes make it worse. So absolutely, we all don't drink enough water. And certainly as a patient, often the tap water from our hospital isn't particularly very palatable. I remember when I was a patient quite a while ago, I hated the water. I refused to drink the water because it tasted of plastic pipes. So I'd get the water from the drinks fountain, either in the doctor's mess, because I had that option, which patients often don't have. But sometimes getting some ice in the water might help it be a bit more palatable, or some cordial, because as long as it's clear, there's no real difference between some blackcurrant cordial and plain water. So if that makes it more palatable and you drink more, then get some blackcurrant. or any other flavor of your choosing. I'm not sponsored by Robertson's.
That's brilliant. Does anybody have any questions for Christian? Because I think I've really enjoyed this tonight, Christian. I've learnt loads from you tonight. And I think we've actually covered everything that people wanted to talk about.
It's a pleasure. I think if you are not getting the answers you want from your hernia surgeon, you're always allowed to get a second opinion. And that second opinion might agree with the first surgeon. And if that's the case, at least you've got reassurance that both surgeons are saying the same thing. Some second opinions can be different because there's no standardized way to fix some hernias. There are lots of different techniques. And when you've got lots of different techniques, it means that there isn't one that's better than the rest. So if you are not getting the answers that you want to get, or you want a second opinion, then you're allowed in the NHS and obviously in private as well to see somebody else and get that opinion. And I can tell you, my hand on heart, I'm never offended if a patient of mine says, I'd like to get a second opinion, please. We're never offended. So sometimes people don't want to do that because they don't want to offend the surgeon that they've first seen. I've never been offended by anybody that has said, do you mind if I get a second opinion? And Stella Smith and I, who work in the same hospital, we often give second opinions for each other for high-risk patients so that we both know, both have an opinion, and we often operate together on those difficult ones so that the patient gets the best outcome. So I think it's important that patients know that. Some people don't feel they can.
And I think if they're worried whilst they're in hospital and you feel as though you're not being listened to, there's always Martha's rule, isn't there?
Absolutely.
So you can always ask for somebody else to come and see you under Martha's rule.
Yeah.
That you should never, if you know your body, so if you're at all worried, then you must ask for a second opinion, and don't feel that you have to be quiet and just put up with something.
Absolutely. And for those who don't know what Martha's rule is, Martha's rule states that you are allowed to ask for a second opinion from a different team, so that it's a team that's separate to the one that's seeing you, and that you get a fresh set of eyes to have a look at you. And everybody has the right to ask for that. So if you're not getting the answers, or you're not liking what you're hearing and you want a second opinion, then you just need to mention that.
And it's important as well to know that it's not just the patient that can ask for that, their family as well on their behalf can also ask for that.
Absolutely.
Okay. Well, I think that's absolutely brilliant, Christian. So I think we can leave it there. And thank you ever so much for your time tonight.
Pleasure.
It's been really interesting and great. Thank you. And
pleasure,
I wish you a lovely rest of your evening.
You too.
And she'll speak to you soon.
I look forward to seeing you at ASGBI.
Yes, I'll see you soon. Thank you. And thank you, everybody, for joining us tonight.
Bye-bye.
Bye-bye. Bye.